Good afternoon, good evening. Thank you so much for joining us for the weekly press briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager at the IMST based in DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you very much, Director Margaret. Good afternoon, good morning, good evening, depending on where you are. So today we are not in Kinshasa, we are in Addis Ababa. Who's this week at the heart of IMST? At the heart on one side because we want to go to visit the country and ensure that the support we bring to the country is responding to their needs. So we've just completed a meeting with the Minister of Health who have actually allow me to do the press briefing from here. And the second part also, all the experts involved in the Mpox vaccination have spent the week in Addis trying to share the best practice and also the way forward. At a time where we have no dose available, how are we going to move forward? So this will be part of our discussion today, and I'm glad that as every Thursday at the same time, you are all with us. Over to you, Director Margaret. Thank you. I'm doing the press briefing on behalf of our Director General, Dr. Jean Casseya. And this week has been quite busy in reshaping how we address the health in the continent. Reshaping in the sense of engaging or re-engaging new partners. As you see here, the AU has engaged a very strategic partnership with the United Arab Emirates, with the sign of a landmark MOU. And within that MOU, there is a high focus on health system strengthening. This is definitely what is needed to accelerate the effort that the member states has been implementing over the years, so that we have a continent that is more and more resilient and robust to address all the health challenges that we are facing. But also, part of this MOU is the role of Africa CDC, which has been reaffirmed its commitment to support the member states in translating the strategic vision into real long-term improvement in public health, as we'll be seeing in the response to Mpox and cholera. Next slide. The previous slide, please. In Malabo also, we had the 7th AU Media Summit to advance Africa's strategic priorities. So this is a critical moment where our head of state convened to assess the progress that has been made since the last summit that they had in February this year. And part of the focus was to set the priorities for Africa continuing development. And definitely, more than ever, health was part of those critical priorities. That's why the budget of Africa CDC ceiling has been almost double to ensure that we have the capacity to respond not only to the different outbreaks, but as mentioned earlier, to accelerate, to support our member state on strengthening their resilient health system. Next slide. Now going back to our public health event, we still have those for cholera, Mpox, measles, and dengue. As will come later, you can see that the number of suspected cases and confirmed cases of cholera are quite high. For Mpox, 24 countries in the continent so far has been affected by Mpox, with 81,000 of the suspected case, with 26,000 of confirmed case. Measles is also one of the key challenges. You can see the increased number of suspected cases, but also the confirmed case. And when you compare the high-risk event, you can see that at the same period, we are already 44 high-risk events that has been declared in 2025, while for the entire year 2024, we were at 72. So much more than half of what we've seen last year. Next slide. So this highlights us that definitely we have to get used to the challenge of answering to the diversity of outbreak at the same time, but also at a time where the resources are more and more limited, reminding us the need to be efficient. So now in terms of Mpox, what are the highlights? So since last year, 2024, 159,000 suspected cases and 56,000 confirmed cases have been reported from 27 African Union member states. In the same period, almost 2,000 deaths among the suspects and 216 deaths among the confirmed cases, which highlight that beyond or behind Mpox, there has been other disease, most likely measles and or others, that has been killing even more than Mpox, which re-emphasized the decision that we've taken in our plan to have a focus on integration, so that while we go look for Mpox, we can also look for those other diseases like measles that can have actually a highest case fatality ratio. We can see some good news. We can see that the testing coverage, which defined the number of people among the suspected cases that have been tested. And we can see that we are moving from 39 to 55.5% in the last 3 weeks. This is the significant increase because it gives us more confidence that we are actually getting the suspect, testing them, and therefore putting ourselves in a better condition to control the outbreak. So in the last 3 weeks, we still have DRC, Uganda, and Sierra Leone that contributed to 74% of cases and 78% of deaths in the continent. 8 countries have controlled the outbreak and have not reported any confirmed case beyond 6 weeks. We were just discussing with the Minister of Health of Ethiopia, which leadership has been very instrumental on controlling the outbreak. So they just discharged the last case last week with a strong emphasis on the surveillance and integration. She was highlighting how they've managed to use polio screening to screen more than 22 million people. While they were vaccinating for polio, they were also tracking the Mpox. It is a very good example of leadership and integration. We have more than 3 million doses of vaccine that has been shipped to 11 countries, and 8 countries are actively vaccinating. However, as we do speak now, and I will come back to that, as much as we need to come back to that, we have 0 dose of vaccine currently available for countries to use. Next slide. So looking at the epidemiologic situation in the continent, we are glad to see the continued trend of decline, both in suspected cases from 2,765 to 2,500, but also in terms of confirmed case with a bit more than 10% decrease. The case fatality ratio is around 0.9%, still below the 1% target. As you've seen, whether we are talking about the suspected case or the confirmed case, we have more than 100% of what we had last year in 2024, while we are just in the month of July. So we see the decline. This is very encouraging, which highlight an improvement in surveillance, but which also remind us that we are on the good track. We need to accelerate. Next slide. However, we have some countries where we see some upsurge and resurgence. We talk about Nigeria, we talk about Zambia, Liberia, Kenya, and also Ghana. So in those countries where we see the increase, we are having discussion on with those different countries to find the best way to control it as it is, to avoid having scenario that we've seen in Uganda, in Sierra Leone, and in DRC. This is really the time where we can push in terms of community-based surveillance so that we can actually identify the case, but also implement the right IPC method and learn from other countries. Burundi has highlighted that one key point action that has allowed them to control the outbreak was the isolation of the case, which means that they were cutting the transmission chain. And this has been instrumental. So those are some of the lessons learned that we are gathering, sharing with our member state, and showing that they can contextualize because different countries has different realities, but at least the best practice can be received and contextualized. Next slide. In Ethiopia, where we are currently, there is no new confirmed case, while last week there were 4, which is quite encouraging. And I mentioned that has been a very good lesson in terms of leadership, in terms of surveillance, in terms of integration. But the discussion with the minister emphasized the need to go further in terms of decentralization of the laboratory, but also in terms of bringing the research component more in terms of trial for the vaccine, trial for the drugs, because the first case who actually died was a neonate. And that this has been, let's say, a trauma when we were discussing. And we should avoid that to come. That also re-emphasized our advocacy on the availability, the approval of the vaccine for children, for neonates, so that we can also protect that population that is so vulnerable and so dear to us. Next slide. In DRC, we are also glad to see that there is a persistent decline in confirmed cases, which has been observed over the last 6 months. We are also glad to see that the testing coverage for last week was 51%, where you remember hearing us highlighting again and again that it was as low as 17%, 20%. Now we are moving, and this is also the result of the intensification, but also the adjustment of the strategy on strengthening the laboratory system, but also the sample transport system using motorbike and other means that can reduce the delay between the time when the sample is collected and the time when the sample is analyzed. Next slide. In Uganda, as you can see, the increase that we've been seeing over the weeks seems to be stabilizing. As we do speak now, we can see a decrease in the new confirmed case. We move from 233 to 172. The death on confirmed case have increased from 0 to 3. And what is also important to emphasize that 66 districts are still active, which means the surveillance should continue, should be even more intensified, especially in Kampala, that alone account for half of all reported cases and slightly less than half of the death among the top 10 districts. We also have other districts that, as we mentioned, we have Wakiso, we have Masaka, and we have Mbarara City, which actually currently has the highest attack rate with 18 out of 100,000 people, while the lowest is seen in Adjumani, in the northern part of Uganda. Next slide. In Sierra Leone, we've had a very interesting discussion this morning. We keep on seeing the progress in the decline on the number of suspected cases, but also the confirmed case. And we are quite reassured by the fact that we can see the indicator moving. While by yesterday, the data that we had a test positivity rate of 81%. They were telling us that as this week, the week 27, they are already reporting 60% of test positivity rate, which means the operation of sending the enhanced integrated surveillance, but also IPC, community engagement is actually bringing its fruit, which is move hand in hand with vaccination. So that continuous decrease. We expect that in the next few days, we'll keep on seeing the test positivity rate keep on decreasing, but also the number of confirmed and suspected cases. This is quite encouraging. And as we see in the next slide, this also contribute to the vaccination. Next slide. So as you see here, the deployment of all those actors, we have the epidemiologists, we have the community healthcare workers, they support active case search. And by active case search, we mean moving household by household, especially in the hotspot. And when they reach in a hotspot, in a household, you see what they do. They engage the conversation with the communities so that by the community engagement, the risk communication, they can actually convince the community on mentioning whenever they have symptoms, because as you know, the stigma around Mpox is quite present in many countries because of the sexual transmission. So this community risk communication and community engagement is critical. But they also add on top of that the contact tracing around the case that where they implement the IPC, but that also where they implement the vaccination of the contact of those suspected cases, but also not only at the level of the household, but really at the level of the lowest area. It can be a quarter, it can be a bigger area, so that they can have a very efficient vaccination at the same time focusing on the hotspot. In terms of support, also, they've received the laboratory equipment and testing kit. That is, they received a part, another part is ongoing. And Africa CDC has also supported $1 million US to the country because they had that incident action plan worth 1.5 million, where they really want in the next 4 weeks to really go as low as possible in terms of the number of cases that they see in the community. Next slide. Other countries that are, as I mentioned, where we see some increase, Guinea is one of them. To this morning, also we have an engagement with the incident manager and the director general of the NPH in Guinea to understand where they are coming from. And they highlight that actually the district affected are increasing, going out of Conakry, which is quite concerning because you really want to control the outbreak at the lowest level. But however, you can see the test positivity rate is around 59%, so they need more support on the community-based surveillance. The good thing is that the testing coverage is 100%. They test all the suspected cases and they provide the result within the 72 hours, which is still a bit challenging, but they are working on reducing that one. The contact, the ratio between the case and the contact is 1 to 3, while we are expecting to have 1 to 20. However, they were also ensuring that the investigation that put in place are trying to allow them to reach the right contact, because you have the contact that may be in the same household, which will be the one we were targeting with when we are talking about the clade 1A, for example, where the transmission is within the same household. But then when we talk about sexual transmission, what happened is that the contact might not be within the household. There might be something else. And it's only through a good investigation that they are in a position to catch at least some of them. So the active surveillance is encouraged. And as they mentioned, they will need some support that the IMST will consider to see how, as soon as possible, we can support Guinea and other countries. Next slide. Now, the vaccination, the vaccine delivery and implementation status. This has not changed much from last week. We still have 11 countries receive vaccine and 8 countries vaccinating. What is changing is that tomorrow Sierra Leone will receive the 50,000 dose of vaccine, which is coming from the first round of allocation. And this will allow them to have those doses to move to the last mile. Next slide. As I mentioned in the introduction, Ethiopia is really at the center of the IMST. We have that very critical workshop on taking stock and documenting learning from Mpox vaccine deployment in Africa. So we have 10 member states, some of them who have been vaccinating, others that are in the process of receiving the vaccine, so that they can share experience. They can share experience on how they can contextualize the most efficient way of vaccinating. The strategy that has been taught at some point of moving around the case seems not to be sufficient. That's the experience that they are sharing on how they've managed to move hand in hand the surveillance, the laboratory, and the vaccination so that they can improve the efficiency in the sense that they reduce the time between the exposure and the vaccination by a contact. Because we know that to be efficient, the vaccine needs to be given within 4 days between the exposure and the vaccination. And that is only possible if we can rely on a strong surveillance system. That has been one of the key highlights. The second one is that we have 0 dose of vaccine currently available. So we were happy to have around in the room the partners, ERA, Gavi, UNICEF, and all others to acknowledge that the different countries has done as much as possible in terms of the efficient use of the vaccine. The research will allow us to assess the impact on different places. But still, now we need more doses of vaccine. The research is also telling us that once we have those doses, we can use innovative approach for Africa, but that has been used in Europe and in the US during the 2022 outbreak on the fractional dose. How with 1 dose, you can be able to vaccinate 3, 4, 5 people, depending on the environment. So in one hand, we have the solution on how to be efficient. This is coming from the member state. This is coming from the research. And in the other hand, we don't have the vaccine. So we need to push, we need to advocate. And I'm glad that the partners in the room were really willing to go back to the country that have given, to emphasize that this is the last investment. If we don't do that, we might lose all the investment that has been gone until now. So a bit more investment in vaccine that can be used as fractional dose so that we have much more dose, much more people actually that will be vaccinated with what we are having. Next slide. Now, cholera. Cholera is expanding in DRC, as I will see, while other countries, we are seeing a different trend. So what we can say as the end of June 2025, which is mid-year, 82% of all the cases are in the continent, in Africa, which also has 93% of all the deaths. 21 of 28 cholera countries are reported in Africa. That's why the call for action has been made, and you will see how some of the activities from Mpox are actually integrating now cholera as we also move forward to have a roadmap and also a continental plan. Next slide. So we have countries where we are glad to see the decrease. We have the Sudan, where you can see that the number of cases are almost reduced by half, 43%, from 1,195 to 674. This is quite important, though the case fatality ratio has increased. And this is also due to all the measures that have been put in place, and of course, the vaccination with the OCV vaccine, though the coverage is around 6.7%. Another challenge in Sudan is, as we mentioned, most of the time, is the access, because the outbreak is occurring in context of conflict, which really challenge the accessibility, but also the implementation of strategy that's aimed to provide access to clear and clean water to the population. Next slide. In South Sudan as well, we can see the decrease. We are not as low as Sudan, but the decrease is 12% between this week and last week. And then we can see that the OCV coverage is quite high, 73.1% in 34 of the 52 affected countries. So we actually expect that in the coming weeks, we will be able to keep on presenting the good result, because when you have a good vaccination coverage and we also have a better access to clean water, then you can have an impact, especially on the hotspot that are mentioned there. But the driver remains the same, whether we are in Sudan, South Sudan, and as we see later in DRC. The flooding, which is an inheritage of the climate change. In Sudan and South Sudan, you have the issue of conflict, which you also have in the eastern part of DRC. And this is, again, an opportunity for us to push the advocacy for peace, because it's only when we have peace that we can be in a position to provide good health to our population. Next slide. Angola is following the same trend, and as you can see, with this very good OCV coverage, 99.6%. So we keep on seeing the decrease, 8% of decrease as compared to last year, to last week. We still have 57% of the deaths that are occurring in the hospital, which means that there are deaths that are still happening in the community, and therefore the surveillance that has been implemented need to be pushed and accelerated. So the country is still expecting the 2 million doses that has been submitted to the ICG. And yesterday with the ICG, it was clear that the mechanism prioritize countries like Angola that are in critical need, but that are also showing progress with the use of the vaccine. Next slide. Now, DRC is really where the biggest challenge is happening currently. You can see almost 30% increase in the number of cases. You can also see in the case fatality ratio, the increase moving from 65 deaths to 124. This is definitely the country where all the eyes, all the effort are being put in place. The OCV coverage is quite low, at 7%, and the hotspots, as we see later, are in the Chopo, the South Kivu, Kinshasa, Maniema, and the North Kivu. Those are the ones having the highest number of cases. Kinshasa, as we come also, is really, being the capital city, is quite critical. But the driver remains the same, the flooding and the poor access to water. Another reminder that the cholera will not be solved from a medical perspective, but only through a multi-sectoral approach. Next slide. So as mentioned already, those are the top 5 provinces: Chopo, Sud Kivu, Kinshasa, Maniema, North Kivu, and then Tanganyika. But Kinshasa being the capital city where the promiscuity is high, especially in places like Kokolo that we'll see, the promiscuity of the population, the poor access to water is a big driver, making Kinshasa, which represent the biggest threat as we do speak now. And the insecurity, especially in the eastern part of the country, you see the Sud Kivu, the North Kivu, really affects the delivery of essential service and medical supply. Next slide. Now, a zoom in Kinshasa, we see some slight decrease in the number of cases from 326 to 304, but you can see that the case fatality ratio is quite high, around 10%. So the hotspots are also known, which is critical so that we can direct the response to Kokolo, Limete, Bumbu, Kingakwa, and Binza Meteo. Those are also the places like Kokolo, Limete, where Mpox has been quite present. So the use of the same community healthcare workers, the same epidemiologists, actually strengthen the integration of the cholera response within the response that is already in place for Mpox. Because that survey, when the community health workers went into the household, they do the surveillance of both disease. But not only the surveillance, they actually engage the community in terms of education, but also in terms of educating on the prevention measure for control of an infection. But again, this is not going to be solved only by using a proper health approach. It really needs to have other ministers on board, the Minister of Plan, the Minister of Finance, the Minister in charge of access to water, so that the comprehensive and long-term solution can be founded and implemented. Next slide. So in summary, we have Mpox that is declining in the most of the high-burden countries, DRC, Sierra Leone, Uganda, as an example. But we have other countries where it is actually increasing: Nigeria, Liberia, Zambia, Kenya, and Guinea. So these countries are really the one that we are targeting in terms of critical support so that we can control it as it is. Last week, we were also discussing with the NPH in Mozambique that have also had their first case on how they should learn from the previous countries on controlling with a proper community-based surveillance, IPC, case management, isolating the positive patient once we have them, providing holistic care so that they really stop the transmission chain. We are also happy to see the increase in testing coverage. We've been below the 30, 40 at the continental level. Now we are at 55, and we believe that with the intensification, but also with the support on sample collection and transport, we will see some improvement. So that when we will see the decrease, we'll be confident that what we are seeing on the slide are actually what is happening in the ground, because the community health care workers and the epidemiologists are doing a tremendous work in the field, in the household, tracking the case, providing support for IPC, but also ensuring that the right information is available, and also guiding on where the vaccination should be implemented. At this point, vaccination, we've learned it's critical. We have no dose, but we have hope. Last year in August, we were thinking the maximum dose of vaccine that could be available for the continent were 20,000 doses, then 200,000 doses. And from there, with the support of ERA, Gavi, and others, we've managed to reach the 1.5 million doses mobilized with Bavarian Nordic, and through the Ministry of the government of Japan for DSC, 1.4 million doses of vaccine, or 1.5 million, which means it's possible. It's possible. We've managed to reach 3 million. We need to reach 6.4 million so that we invest and protect our communities. This is not charity. This is not help. This is really investment. As cholera is concerned, the burden continues to decrease in Angola, South Sudan, and Sudan, but it's rising in Kinshasa, especially in the Chopo and in Kinshasa, and also in the Kivus that we know is affected by the crisis in the eastern part of the country. And this requires not only attention, but action. And this action is being integrated through the Mpox currently. So while doing that, we are finalizing the roadmap and also the continental plan, which has been requested by our head of state and government in the call for action that was launched 2 to 3 weeks ago. So you can see the progress, but you can also see that lots has to be done. But now I will be happy to answer some of your questions. Over to you, Director Margaret.
Thank you so much, Prof. Let's take the first two questions. We have one here that talks about what has been the most challenging aspect of handling multiple simultaneous health emergencies on the continent, and what gives you the most hope about Africa's ability to meet future pandemics or mass health crisis. You can take those first. Over to you, Prof.
Yes, what has been the most challenging in responding to the multiple outbreak, and how can we have hope? Actually, the two questions are really related. And then we have most of the countries. Uganda at some point was dealing at the same time with Ebola and Mpox. Now we are talking about Sudan, South Sudan, DRC. We're dealing with Mpox, but also cholera, measles, and others. At the time where the investment, the support actually from the US government and others has significantly reduced. So what is giving us hope is when we are in the room with all our colleagues like we were yesterday and today, and we can feel the passion for efficiency, for trying to find a contextualized and homegrown solution. Initially, they received some strategies to be implemented, and they realized that they were not working perfectly in their environment. They were promised at some point to receive some funding, but the funding, the time the funds arrive, the outbreak is not waiting. And they had to actually find solution, homegrown, to address those different outbreaks. So one key things, efficiency, integration, as I mentioned just before, using the same people, the community healthcare workers, to go in the community. And when they go into the community, what they do is they build trust. And when trust is there, it makes it a bit easier or less challenging for the actors to implement response to different outbreaks at the same time. So yes, we have hope because we have passionate people who are in the field working every day to ensure that our continent is protected.
Thank you, Prof. Let's cross over to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor. Kemo, if you can hear us.
Hello, can you hear me?
Yes, we can hear you. Go ahead.
Good, thank you. Thank you for the presentation. I have a question on today's presentation, and I have one clarification I would like Dr. to make on previous presentation. That's the last episode. First, the question, we, as the numbers show, cases are reducing in Sierra Leone, and we are seeing, unfortunately, cases rising in Liberia and Guinea, which surround Sierra Leone. And we saw that these were countries that had these cases, Mpox, before Sierra Leone. You know, so what does this mean? I mean, considering the close relations between these countries, what does it mean, and what would you advise for the three countries to do to make sure that we prevent, you know, if there is any cross-border infection, we prevent it? The clarification I need was, in the beginning of last week's presentation, you mentioned the viral sequencing, the progress made in Malawi, and you cited the fact that because of that, a new strain, I stand to be corrected, was identified in Sierra Leone. That's 2B G something. I would like clarification on this.
Thank you. Back to you, Prof.
Okay, thank you so much, Kemo, one, for being there all the time and for following. I think we are accountable to you, and then through you, we are also accountable to our community. So the clarification, it's actually in Sierra Leone that the sequencing has shown the clade 2B G1 with the support of different partners from Africa CDC, from the Nigeria laboratory. So now the first question was, where was this coming from? And then they were able to track and tell us that the actual, we call it ancestor in terms of strain, was coming from Nigeria at some point. And with the different development, different mutation, this first mutation occurred in Sierra Leone. Now, that's bring me back to your other question, where we need to keep on this sequencing in neighboring countries where we see the increase. You mentioned Liberia, you mentioned Guinea, who are neighboring countries. And in the discussion that we have this morning, we were having both Sierra Leone and Guinea, where we were discussing on how we can learn from the best practice that we've seen in Sierra Leone with what they are doing now with what they call the enhanced integrated surveillance. So if that is implemented now in Guinea, when they still have a small number of cases, then they will put themselves in the position when they can track. And the difference between Guinea now and Sierra Leone is that Sierra Leone had the opportunity to get the vaccine once they were still available. So at this point of time, Guinea might not receive the vaccine because they're not there. So they need to be more aggressive on the surveillance, on the IPC, and it was good also to hear from Guinea when they were highlighting today that they push to isolate the positive case, to take care of them. Unfortunately, some of them refuse to stay in the treatment center, and then they go back to home. And then when they go back to their house, that's also where they keep on transmitting. So some important efforts are will be put in place in terms of risk communication so that we can engage those people so that they can stay in the hospital, but also provide what is needed within that. And the last point is the collaboration, the cross-border collaboration, the capacity to actually test the case at the border. And Liberia was actually showing great leadership by the time Sierra Leone has a few cases, going to the neighboring country, support on the surveillance. So quite a number of lessons has been learned from the different countries. But the key thing I can say specifically for your answer is really the cross-border collaboration and learning from the experience of neighboring countries.
Thank you, Prof. Let's cross over back to the floor. We have Carmen from Politico. Carmen, you have the floor. Welcome back.
Thank you so much, Margaret. I just want to go back to what you were saying about the lack of vaccines, and I didn't catch if that was for Mpox. I didn't catch if that was for specific countries or if it's all countries that are now experiencing an outbreak have run out of vaccines. And I was wondering if the U.S. still plays a role. Are they still, is the lack of vaccines also due to sort of like their pullback from global health? Like, can you give us a bit more details into that? Thank you.
Thank you, Carmen. Back to you, Prof.
Okay, so that's a very good question, and thanks you for coming back, Carmen. So first of all, when we say that there is a shortage of vaccine, it means that the fund to buy the vaccine are not there. 400,000 doses of Mpox vaccine are currently with Bavarian Nordic, which is a manufacturer for UNICEF. But UNICEF have not managed to raise 33 million so that they can acquire those vaccines. So what is critical now is actually the money to buy those vaccines. And the discussion that we had last week with Bavarian Nordic is that they are willing to produce more doses if there is fund to acquire those doses. In our plan, we estimate 6.4 million doses that we need for the continent, because don't look only for the countries that are currently in the outbreak. We should also look at countries where Mpox is endemic. CAR, DRC. Why? If we don't do that, we'll keep on having Mpox outbreak, and we keep on having different mutations that will lead to what we are seeing right now. So we really need to see those two angles, the endemic countries where we want to reduce at least by half the burden, and the other countries where we want to reduce the outbreak, to control the outbreak. But the situation now is that we have 8 countries. We are talking about 6 countries 2 weeks ago. Now we have 8 countries that are on the pipe waiting for vaccine. The Minister of Health of Ethiopia was also highlighting that at the time they had no case, they did not expect vaccine. But now that they had some case, it will be great. They need some vaccine so that they can at least, once they have the case, vaccinate around so that the contacts are protected and they can control the outbreak. So now for the position of the US government, there were some doses that unfortunately went down to the shelf life, in the sense that for a vaccine to be shipped to a country, we need a minimum of 6 months before its expiration. to ensure that the vaccine can arrive in good condition and also allow the country to implement the vaccination. Because as you know, vaccination is not done only with the vaccine. You need the syringe, you need the human workforce, which means you need those operational funds. And this was also part of the discussion today and yesterday with the partners, is that with the vaccine, we need also to support in terms of funding, while we also push and encourage the member state to also have domestic funding so that they can implement those vaccinations. So part of the USG dose have actually went below the 6 months. So they are no longer available to be shipped in any other countries. So there are still some few that are remaining, but the conversation is ongoing. And we hope that by the time we conclude the conversation, those vaccines will have not also gone under the shelf life.
Thank you, Prof. We have Paul from the Lancet next. Paul, you have the floor.
Hi, can you hear me?
Yes, we can hear you. Go ahead.
Yes, so I know the Africa CDC sends its scientists and experts across the continent to respond to emergencies. And we know that it's not the visa requirement for individual African countries are different. And so I'd like to know what concrete steps Africa CDC is taking, both externally and internally, to ensure that African scientists and public health professionals can move freely across the continent to help in intervening and in supporting emergency responses and other necessary activities. Thank you.
Thank you. Back to you, Prof.
Yes, thank you. So you are giving me the opportunity to congratulate the government of Kenya that has made visa-free for all the Africans. So no need for ETA, just show up with the African passport and you can have access. And you are right. This is a big challenge in terms of getting the visa on time to be able to deploy the actors. But we have one advantage as Africa CDC being from a tool, an instrument from the African Union. Most of the country will actually accept what we call the note verbal, where we will request for the countries to facilitate the migration of our actors. So this is a process that is actually helping us in many occasions, in many countries, to fast track the capacity for our colleagues to intervene. But now you start by talking about scientists. So scientists are not all the people responding to the emergency. So unfortunately, we have scientists that are not able to attend some of the conference because of the visa issue within the continent and also out of the continent. This is also something that Africa CDC take very seriously on engaging so that we have a free movement of our scientists within the continent and out of the continent, so that we can contribute also to the global knowledge, the global good, as we are talking about health. And this is definitely an opportunity to remind us this important advocacy piece. Thank you, Paul.
So we have the next two questions. We have Charles Chikapa, a journalist in Malawi. The question is, Malawi launched its pathogenic genomic survey and strategy implementation plan a week ago. Scaling up public sensitization campaigns through the media is one of the recommendations. Would Africa CDC consider supporting capacity building for media? Then the next question we have here is Lisa Shearing, the news editor for CIDRAP from the University of Minnesota. The question is, can you comment on the Mpox situation in Mozambique? Do your experts know yet what clade is involved and how it's spreading there? Back to you, Prof.
Thank you very much, Director Margaret. So the first question, I was thinking that we're moving toward strengthening the genomic, but then we end on how do we strengthen the capacity of the media. Do you want to comment on that?
Yes, sure. So we have a couple of media engagement, quarterly engagements with the media. Currently, we have one that's coming up. We did one during the first and second quarters. We have one that's coming up in the third quarter. I will be sharing the details of that, where we have our different experts speak to the media in terms of the work that we do on the technical side, which helps, of course, with synthesizing information to the public as well. So I will be sharing those details with the media across the continent. Back to you for the second question.
Thank you. And on that first, I was privileged actually to be part of one of those workshops where we were engaging some of the journalists across the continent, because we need, as we do every Thursday, and we really thank you for that, to have that conversation so that you can, one, get the right information, but also your question guide us and reminding us that we are accountable to you and to the community that we are serving. So in Mozambique, we have a conversation a week ago with Dr. Eduardo, who is the Director General of the NPHI, on understanding the situation that is happening currently in Mozambique. So there were 3 cases that was detected. There was two men and 1 woman. So with no history of travel. So that was the first challenging point, because if they have not traveled, it means that the transmission may have been ongoing within the country, which is at the border with I think with Tanzania, if it's correct. So the conversation is around how Mozambique, with those 3 cases, can learn from countries like Burundi, others who have actually been able to control, relying mainly on surveillance, mainly on the management of patients in treatment center, in health facility. And then we were quite happy from the feedback of Dr. Eduardo for the capacity that the country has in terms of laboratory that are decentralized, but also on the fact that the health facility at the decentralized level can actually isolate some patients. So though they were thinking of using the home-based care, which country use when they already have a large number of cases, for countries that still have a reasonable number of cases, the best thing to do in Mozambique, that's where they're heading, is to ensure that every positive case is actually isolated, being taken care of, so that he provide the holistic treatment, which include the psychological, the food, and the clinical. At the same time, which this limit the possibility to spread the disease in the community. So we are yet to receive the result for the sequencing, and once they will be available, we will be happy to communicate to you next week.
Right, let's take the last 2 questions. We have one question here from the chat box. The question is, could you give us an update on the many research initiatives connected to the Mpox IMST in the DRC? You have previously stated that there were close to 24 research projects underway, all connected to Mpox. Any breakthroughs yet? So that's the first question. The second question here is on this is from a technical officer from GPAGO. The question is, could the rise in the reported cases of Mpox be linked to enhanced screening efforts in specific countries? That's the second question. Back to you, Prof.
Okay, thank you. Yes, so on the first question on the breakthrough of research, I will say yes, but we may have a different interpretation of breakthrough. For us, as per now, the most critical is how the research, the operational research, can guide us on shaping the way we respond to this outbreak. So we've conducted as IMST a social behavioral study that has been implemented in 9 countries. And the result, quantitatively and qualitative, was quite interesting on telling us that more than 80% of the people that have been interviewed have actually been exposed in terms of communication about Mpox. But the challenge were on the actual understanding of the disease. That was one of the critical. which push us to give more emphasis on the messages that we send to the community. Now, the second point, though the study took place mainly in the capital of the 9 countries, they highlight that radio, TV, and health workers were the most trusted channel for people to access information on Mpox. So now, if and as we have few resources to respond, we might not put a big billboard on Mpox. We'll rather having some messages that will be communicated through radio, to TV, and also ensure that the healthcare workers and the community healthcare workers will move house to house to provide the right information. So we have a couple of those information coming from that study that for us is quite critical. On the diagnostic part as well, we've been able to have some laboratory tested multiplex that can detect Mpox, measles, and chickenpox, which allow us, depending on the environment where we are, to leave no one behind. When someone comes, as I mentioned in the beginning, we were having much more death in the suspected case than in the case confirmed of Mpox, but we did not know which disease it was. Now with those tests, we will be able to say this is measles, this is Mpox, and therefore implement the right measure. So far, those are the key research, but some of the research also take a bit more time. Now we are pushing for the vaccine effectiveness. We see some trend where the vaccination has actually led to a decline on the case, but can we attribute that to vaccine only, to other method? We need to have those studies that are actually being implemented. So now on the question of whether the increased case is actually the result of enhanced screening effort, in some places, yes. For many weeks, we've been highlighting a decrease of case in Uganda, especially in Kampala. There were no cases that were reported. And as soon as they had the capacity, the operational capacity to do the active screening in the community, they've managed to track and find some new cases. That's why most of the time we talk about the test positivity rate. That tells us whether the case are the one that we see at the health facilities or whether we are actually seeing them in the community. When we are around 30 to 30%, yes, then we are a bit more confident that we have the active screening. And as going on right now in Sierra Leone, we can see the testing positivity rate declining from almost 100% in some districts. We are now around 60%, which means that we are catching more and more the case in the community. But catching the case is not the end of the game. What is critical is the intervention around that, the communication in the community so that we avoid the stigma, the IPC intervention so that we can ensure that people are protected, and whenever it's possible, the vaccination of the right people. Because once again, we want to highlight efficiency, efficiency, efficiency. Over to you, Margaret.
Thank you, Prof. And with that, we have come to the end of the briefing this week. I'll hand the floor back to you for your closing remarks. Over to you.
Thank you, Margaret. Thank you for our colleague journalist for being with us over and over. And thank you, I really want to thank our colleagues who are in the field, who are dealing, as you rightly asked the question, with multiple outbreaks, with limited resource, but they are there. And we really want to acknowledge those efforts. And we look forward to see you next week at the same time. Thank you.